Hello and welcome to the IMEDX Best of Day series here at our annual hematology meeting in San Diego, California. My name is Dr. Joseph McHale. I'm a hematologist at Mayo Clinic in Arizona, and I have joining me today another colleague from Mayo Clinic, Arizona, Dr. Ruben Mesa, who is a professor of medicine and chair of our Division of Hematology and Medical Oncology. Ruben, always good to see you.
Thank you, Joe. It's a pleasure to be here.
It's wonderful to have you here. Now, Ruben, we're going to triple tax you today.
There we go.
Because in this set, we're not only going to talk about chronic myelogenous leukemia, we're also going to talk about myeloproliferative neoplasms and as sort of a bonus, mast cell disease. So why don't we start with chronic myelogenous leukemia, obviously a disease that over the last decade has had tremendous evolution, but I understand there's been some very interesting data presented here. So talk to us about CML.
Correct. And no, I mean, without question, as we look at hematology, just the fact that there are so many different new therapies in this whole myeloproliferative neoplasm space, is just really a comment on our entire field, where we increasingly have, options in this whole spectrum of diseases. There was even an abstract yesterday on Erdheim-Chester disease with a new therapy. So there's truly quite a bit.
Wonderful.
Now in CML, this is a very mature market, clearly, where in CML, we have a whole variety of tyrosine kinase inhibitors. They've been very impactful. However, there still are very difficult cases. They're the minority, but they can be very difficult. So there was a very interesting abstract presented on a new therapy that tries to target BCR-ABL in a slightly different way that doesn't lead to the resistance that we've had issues with before. So this agent, ABL001, tries to insert itself into the pocket in a different way that doesn't breed resistance. A clinical trial in patients that have failed more than 2 TKIs in the past are really showing very, very significant activity. So that's going to then proceed into, again, studying this difficult group of patients as well as a subfocus for those with T315I. Most patients with CML do well these days, but this group with more difficult disease, we again struggle with, do we use a third or fourth line agent or allotransplant? So having more options for that difficult group might be very helpful.
And how well tolerated was this agent?
Pretty well tolerated.
People with TKIs are used to minimal side effects, generally speaking. So
pretty well tolerated. A concern in that group has been around cardiovascular toxicities, and that has not been seen of late. But that's probably the one we're the most sensitive to. That entire class has had an increased predisposition to arterial vascular events and arrhythmias, but hopefully won't see much of that going forward.
So not obviously quite ready for prime time yet, but something to be watching for. Is this something you think maybe even in the fairly near future will add to the armamentarium of CML drugs?
I think potentially in the near future. I think as well another key thing I would highlight from CML from this meeting is a much more maturing experience with the issue of discontinuing TKI therapy. So there was an entire section of oral abstracts just on studies that look at discontinuing TKIs. For individuals, they have chronic phase CML, they've been on a TKI for several years, they've had a major molecular response, and what have we learned from that? Overall, we learned that increasingly it's getting closer to becoming able to be utilized in clinical practice. It's not quite there yet, but a lot of things have been identified. What depth of response, and probably whether one has a major molecular response, which is a 3 log, or a 4.5 log, probably either are probably equivalent. Clearly, the longer someone's been on a TKI, the more likely they are to have a unmaintained remission. So if they've been on and had that sort of response 5 years, 6 years, 7 years, of which increasingly we really have some long responders, the more likely they can come off with a lower likelihood of relapse.
So in an era and a day of cost increases and worry about costs, could this paradoxically lead to us to a point where we can actually stop more and be able to be more cost effective by not over-treating people for too long?
I think there's clearly been a goal, I think both for the economic reason as well as clearly, there are agents that have their own toxicities. Of course. Particularly this whole issue of cardiovascular effect and such. So great interest in seeing, how can we stop it in a group of individuals. And then, of course, there's more laboratory-based data trying to see are there other ways to eradicate minimal residual disease in this group. not quite ready for prime time, but can you take that good responder at 2 years, intervene with some other method, immunologic, CART, whatever it is, and finish eradicating a minimal residual disease state. So still more to discover in CML.
So in the discontinuation world, is that not quite ready then for prime time either?
It's not, but it certainly blends into practice. I'd say in my practice, individuals, if they have had these long-term responses, if they're having difficulty tolerating therapy, we certainly discuss it. And certainly where they are along life's journey is a part of where that fits into
And then
play.
watch them closely for any evidence, obviously, of
Watch them
molecular
closely,
relapse.
and with obviously some shared assumption of risk, you might relapse. However, studies that have re-challenged people who have come off and relapsed, in general, they re-achieve a response.
Excellent.
Nobody knows long-term are they compromised to some degree, but it will probably become an increasingly important strategy, particularly on a global level. I mean, these are very expensive medicines for people to be on.
Absolutely. Well, let's turn to your deepest love within myeloproliferative neoplasms, if we can. Let's talk a little bit more about other MPNs that have been profiled here at our annual meeting.
Sure. Well, a few key themes. One is really for the first time mature data regarding the use of pegylated interferon as upfront therapy for patients with polycythemia vera or central thrombocythemia. It's been used off-label in a whole range of single institution phase 2s, but it's never really been large-scale studies. One that I helped to lead with colleagues in the MPD Research Consortium, which was pegylated interferon alpha 2A versus hydroxyurea in PV and ET. And the second, a European study of a every 2-week ropeg interferon, which is a pegylated interferon alpha 2B in high-risk P vera, again versus hydroxyurea. Discussed both of them in parallel because the results were fairly similar, in that through the first year of experience, the therapies are fairly equivalent. So positive depending upon how one looks at it, but at least interferon is non-inferior for controlling counts, preventing vascular events, and as we did a variety of quality of life metrics. Certainly both have advantages and disadvantages along the way in terms of the side effect profile. There's longer term data in the every 2-week drug, the ropeg interferon, suggesting after a year we might anticipate more molecular responses in interferon. It's a therapy that really has quite a lag time in terms of its maximal benefit, so that longer duration of therapy will be key. I believe that's probably true for both sets of studies. These are long-term chronic diseases in which the impact at 5 years, 10 years is probably our area of greatest interest. And so we really kind of look at this as an interim step, but an important one. It's a therapy that's not been approved up to this point. Patients have gotten it off label. So it's an important addition to the armamentarium in the mix.
And what are the tolerability of that? We have had a lot of experience using it in multiple diseases where in some patients it can really, to a certain degree, impair their quality of life, especially if you're going to have such a long-term trajectory use of it. How is it tolerated in these 2 trials?
So overall, it's tolerated pretty well. It's used in very modest doses compared to most people's experience. I know it was used in myeloma before. You guys really have enjoyed, such a run of great drugs, but it wasn't a great success in myeloma. It certainly was used in solid tumors and CML, in almost punitive doses. 5 million units 3 times a day. I mean, just
You're kind of giving people the flu, really.
Yeah, these are very, very modest doses. The pegylated interferon alpha 2A, 45 to 90 micrograms a week, which tends to be a quarter to a half the dose that patients with hepatitis C take. So it's low dose, it's chronic. It's felt that it does have an anticlonal effect, and a bit like the TKI discussion, part of the hope is that it would be not an indefinite therapy, but that there may be a period of time, again, is that 2 years, is that 4 years, but that it may be a segment of therapy to hopefully achieve some sort of immunologic remission of sorts with the disease.
Other areas within myeloproliferative neoplasms that have been profiled this week?
So I think a few key things. One, clearly evolving information with ruxolitinib. It continues to remain our only available therapy. 5-year data continues to look very good in terms of survival. There are some real deep responses in terms of bone marrow fibrosis. Some interesting combination studies. I think really maturing data suggesting that combination with hypomethylation therapy for patients who are moving toward acute leukemia might be an option. Particularly patients on Rux first, get the dose settled, and then add in your azacitidine or your decitabine. There's some other combinations with PI3 kinase inhibitors, where a trial led by Mike Savone at Vanderbilt that we are participating in that has some interesting activity. In addition, maturing data with other therapies under development, further long-term information regarding momelotinib. Phase 3 data will be coming out soon, but long-term data from our colleagues at Mayo Rochester that look favorable in with segments of those individuals. So a lot of information.
So ruxolitinib monotherapy still kind of the standard, but
correct.
Encouraging combinations, maybe other JAK2 inhibitors down the line.
Yep. And then finally Pacritinib. So a late breaker tomorrow, a study which we participated in, the PERSIST-2 study. Pacritinib, helpful in patients with marked thrombocytopenia. PERSIST-1I had presented at ASCO last year that demonstrated good activity for spleen and symptoms in these patients with low platelet count. However, there was increased mortality in that study. So this second phase 3 was of great interest to see whether that mortality was related to adverse patient selection or drug toxicity. This study, which was quite positive, particularly for those with a more modest dose of pacritinib, 200 BID, showed superiority compared to best alternative therapy for individuals for spleen reduction, symptom improvement, as well as survival, without a sense of any increased toxicity in that group. So favorable data. We hope that in aggregate we'll find potentially a path for this therapy moving forward.
So looking at the myeloproliferative neoplasms as a whole, then, if I could make you a Ruben prophet for a moment, what do you see down the line in the next few years coming for them?
Well, I think many things. One, we're increasingly understanding about molecular profile, as well as many more mutation-directed sort of therapies. There are different approaches that are in development regarding trying to target calreticulin since it's on the cell surface, immunologic therapies, and as well as really more design-targeted therapies. One of the most exciting abstracts was in mast cell disease presented yesterday with an agent called Blue-285, which was designed to be specific for the D816V mutation in patients with systemic mast cell disease. In the past, we've used a whole spectrum of non-specific myelosuppressive drugs that haven't been overly active. So it's still a phase 1, but however, they've seen profound specific cytoreduction of mast cells in these patients with very meaningful improvements in organ dysfunction and other pieces. So really quite exciting. In a
disease we haven't had much to
we really
offer
haven't
patients,
had much. Very specific, very targeted, and very exciting. And perhaps we'll be able to see those platforms be able to further utilize in the future for more mutation-specific, diseases. We know certain mutations such as ASXL1 and others are really associated with very adverse prognosis. And might we better understand why these different molecular mutations are giving individuals particularly bad disease, and how we might be able to target them.
Well, it sounds like it's been a great meeting for the myeloproliferative neoplasm world.
It's very exciting times.
Excellent. Well, we really appreciate you joining us today. Ruben, it's a delight to interview you. It's always insightful from the biology right through to the clinic, and so we appreciate the great work that you do in joining us today on this series.
Great. Thank you very much, Joe. It's always a pleasure being here.
Well, thank you again for joining us at our Best of Day series here at IMEDX. We've had some very insightful thoughts in CML and other myeloproliferative neoplasms with Dr. Mesa. We appreciate you joining us. We look forward to having you join us in future activities. Thank you very much.